Are you curious about Gestalt language processing? You are not alone. Join me, Corinne Smoose, and speech therapy PD for our podcast, The Gestalt Get Together. Our episodes try to balance the enthusiasm and excitement about GLP and its associated intervention ideas, as well as a healthy dose of skepticism about how to understand and integrate this paradigm shift into your career and the field at large. We hope that you can get together with us to learn more about Gestalts.
Welcome to Brainstorms, Functional Neuro Rehab for SLPs, presented by SpeechTherapyPD.com. This podcast is designed for the adult medical speech-language pathologist. Most of our audience members work in settings such as acute care hospitals, private practice, outpatient hospital clinics, and inpatient rehabilitation hospitals. Each episode has an accompanying audio course on SpeechTherapyPD.com and is available for 0.1 ASHA CEUs. The content of this course is based on the research and experience of the presenters. The listener is responsible for researching to determine if the information and skills taught are appropriate for their clients, students, or patients. SpeechTherapyPD.com does not necessarily endorse, recommend, or favor the information shared, nor any of the claims, opinions, statements, offers, or services made by the presenter.
Hello and welcome, everyone. My name is Renee Garrett, and I am your SpeechTherapyPD.com podcast host for Brainstorms, Functional Neuro Rehab for SLPs. Before we get started, we have a few items to alert you to. Each episode is 60 minutes and will be offered for 0.1 ASHA CEUs. Here are the financial and non-financial disclosures. Joining us tonight is Megan Battles Parsons, and Megan receives a salary from Methodist Le Bonheur Healthcare in the University of Memphis. She receives an honorarium for being a guest on this podcast. Megan, as far as non-financial disclosures, is a participant in ASHA's Leadership Development Program. My financial disclosures are that I am the host of this podcast and receive honorarium and other financial reimbursement from SpeechTherapyPD.com as the host and as a speaker on some of the webinars. And for non-financial disclosures, I am the current secretary of the Communication Disorders Foundation of Virginia. I also am a participant in ASHA's Leadership Development Program, as well as in SIG-2 neurocommunication disorders. I think I didn't say that exactly correctly, but it's SIG-2. I do know that. Now, without further ado, we welcome our guest, Megan Battles Parsons, PhD, CCC-SLP, CDP. Megan is a medical speech-language pathologist and visiting assistant professor in Memphis, Tennessee. Through both roles, Megan actively mentors future speech-language pathologists in the clinic and in the classroom. As a certified dementia practitioner and participant in the American Speech-Language Hearing Association's Leadership Development Program, Megan also advocates for patient education and informed consent, ensuring individuals and families are empowered in their healthcare decisions. Outside of work, she treasures her role as a wife and mother to two energetic boys, ages 1 and 4. Welcome, Megan. It's so great to connect with you again outside of our shared role at the LDP. And so, thanks for being here.
Of course. Okay.
So, what we're going to talk about tonight is a big, I think, passion thing for both of us, and that we both are very active and feel really passionate about not only the clinical aspect for students and clinicians in education, but also our patients. And so I know you've done a lot of work with clinical practicums for graduate students. And so just to start off, can you kind of walk us through how you structured your clinical practicums for graduate students?
Yeah. So I first started taking students, I think like 3.5 years ago. And my first student, it was just, the wild, wild west. We were just hanging on for dear life, trying to figure this out together. And then I slowly but surely start asking the students, what do you need from me? Or what are you wanting? Where are your fears? Where are your stress points? What are your strengths? The feedback I kept getting was that a lot of the stress points were not understanding the expectations, especially like what was being expected of them in that moment, that week, with the setting. So I am at an acute care hospital. It's a smaller hospital in Memphis. So I refer to it as like, we get the milder strokes, we get the dementias, we get the community illnesses. We're not getting your traumas. So we can kind of slow down a little bit compared to, and sometimes it's a little bit easier introduction to the hospital, I think, for students than like jumping into like our level 1 trauma center or even our larger academic institution within our hospital settings. And so about that time, I think I started also I became an adjunct professor at Memphis because I had my PhD and I was developing a course, and I just had this light bulb moment. I was like, why don't I start treating my clinical practicum like a class? They're in classes already. They have these expectations and assignments and whatnot. Like, they're familiar with the structure. I think it just helped me with my ADHD brain to kind of like structure things a little bit better. So I just started with like creating an outline of like, what are the key concepts that like once they leave here, I need them to understand if they were to transition into, say, this might be the only clinical practicum they ever have in acute care. Like, what do they need to know, or what foundational things do they need before they go to that higher level of care hospital? And then I started kind of breaking it down and mentally walking through like the start of the semester, like, how do I scaffold this so that they're not so overwhelmed with everything all at once, right? Like, we're not jumping in and doing a full clinical swallow eval day one. So I just like created that outline or that syllabus for the clinical practicum, and just like, I don't know, just kind of like structured it for them. And I got a really good feedback from the students. They're like, oh my gosh, this makes it so much easier. And the way I had it is like, week 1 is just like, welcome to the hospital. Like, buckle in. We're about to be running all over the place. You're going to be overwhelmed with just like everything. There's a lot of noises. You're going to get lost in the hospital 1,000 times. Just like exist in the hospital. That's all I want you to do. And then like week 2 is more like, okay, well, now we're going to start chart reviewing, and we're going to chart review together, and we're going to talk all about it with the expectation by that week 3, you are starting to develop some level of independence in this chart review. Right. So like, it builds on each other. And then that week 4, because we've already gotten through that, you're going to keep chart reviewing. And now we're going to add on a new skill. The next week, I expect you to be a little bit more independent by it and just kind of keep adding it on each semester. And I felt like that was I don't know. I'm sorry. Can you hear my kids screaming in the background? So I do apologize for that.
We can edit that out. Also real life.
Yeah. That's that energetic 4-year-old I was talking about that I love so dearly. So yeah, that's just kind of handing that to them. And they were like, oh, this gives me a little bit of ease. It reduces that anxiety because now I'm only having to focus on like one core skill. And then by the time we're 6 weeks in, suddenly like they're doing a full clinical swallow eval, like, cranial nerve, like the back of their hand, because we've already worked through each individual skill each week while they're observing everything else while it's happening.
So no one got pushed off the pier straight into the water like we did.
Yeah. Yeah. And so they get to watch me do all of it. So they're still like, getting that they're still getting the practice and still observing and able to ask the questions, but it's just what I'm asking of you is just very structured. And the beauty of it is that I'm not, like, some people would say, well, you're limited, right? Like sometimes you have students who are a little bit like slower to grasp the concepts. And sometimes you have students who are just like in it to win it from the very beginning. And so then it's like, okay, well, then we move through it faster, or maybe we skip that second week of like, you've already mastered it by week 1, or you've demonstrated like competency, then we can kind of move things along to where essentially you are, doing things on your own a lot faster. And you can kind of structure it around your setting, your student, and your expectations. When I first started doing this, my coworkers they kind of laughed at me a little bit. They were like, what do you mean you have a syllabus? And I was like, well, let's think about it. Well, so and let me explain. I'm in a setting where I'm the adult therapist in the hospital, but we also have a pediatric outpatient. So like all of my other therapists that I work with, the speech therapists are pediatric. And so they were like, well, that would never work here. And I was like, but think about all of the skills that like you wish, or the knowledge you wished you had when you first started.
Yeah.
So like one of my coworkers is autism is a huge, she has a lot of patients with autism. And she was like, oh, no one ever really taught me about like sensory like stuff and how to like work with those sensory needs and help de-escalate the patient and help them regulate their systems. I wish I had gotten some information on that. So like maybe week 6 or whatever, you focus on, okay, now I really want you to like, when our students start to like need that regulation or need that sensory movement break, I want you to jump in there and start helping them regulate their systems. And she realized like, maybe she doesn't need to go quite as structured as I do, but she actually started like implementing kind of like a book where she just gives them information and it's like, okay, this week we're going to focus on this week we're going to focus on that. Because the students at the end of the day, they want to learn, but sometimes it's really hard when they're being thrown into the deep end to figure out, there's all this stuff in the water, which one is the actual life raft? There's a lot of other things that they could be focusing on, but like finding that life raft and grabbing those skills as they need them.
Well, and I think too, for a lot of students, that expectation, it's fear of the unknown when you go into your clinical practicum, especially the ones off campus, because you have either heard something about that supervisor or you have known someone who may be with them or you haven't. And then that's even worse, right? Because you don't have any feedback from another student or future colleague that that was their experience. So I think that's great because it does lay out expectations, not only for the student, but it gives you a roadmap too, because being a clinical instructor, whether it's a clinical practicum or a CF mentor, that's not an easy role a lot of times, particularly like you mentioned, if you have someone who isn't a top tier strong type A++, maybe they're a student who does well and is adequate, but maybe isn't the go-getter hardcore, or maybe lacks even some self-confidence, because I think we've all seen that. Maybe they are going to be a great clinician, but that self-confidence piece is huge when you're developing those skills, because most of us have no clue what we're doing. Yeah. And if you don't have a clear expectation, that is a really difficult thing to navigate. And so one of the things I think we talked about, and then I saw some questions, was themed weeks. So you talked a little bit about that, having these expectation for weeks. But are there specific other like independence building activities that kind of contribute to the students' growth and their learning experience and their confidence building?
So like with the themed weeks I kind of picked out, especially for like the acute care, is more like, okay, well, intro to the hospital, like they need to learn how to chart review and like understand Cerner, because like that's what we have. They need to understand like how to do a cranial nerve exam, remember their cranial nerves. They need to understand, right, the different things that you can do during the bedside swallow, like speech language cog, what are the components we're doing in that? And then we get into like the modified bariums and goal setting, and each week, like, right, so they're just like, that's where they can like really put in their focus and worry about, right? So it's like, sure, you might be doing these other things while it's going on, but like I'm okay if you're not great at it at this point, because the expectation isn't there yet. But then once we get to that themed week, it's like, okay, we're all in on this topic this week.
Okay.
And so now you really need to this is where I'm looking for you to show me your skills. And really demonstrate your mastery of this topic. And so it gives them, and then I also, because I have no chill and just kind of like take a project and scale it up all the way, I created this like a guide for them. And I think at last count, it was like 185 pages plus, which sounds, I will acknowledge, to someone on the outset, it sounds insane. But
you need to publish that. You need to publish that.
I know, right?
Make some money.
I know, right? I should. But it's like 185 pages, but it focuses on each topic, because what I was starting to realize too is with these students, and I'm not saying that this is feasible or functional for every placement or every person, but even like pulling research papers or pulling like, hey, I really enjoyed this podcast on this topic, like give it a listen, and on this thing, this topic we're talking about, because what ends up happening is like these students are having these courses where they're expected to regurgitate information, and then we're expecting them to come to our placement and to be able to apply it. But sometimes something gets missed or lost in the course to where suddenly they can't apply it because they've either forgotten about it, or when they did learn about it, it just didn't click. And so I was seeing suddenly, like, it was like the wheels were turning, and my students were trying really hard for it to click, and it just wasn't. And so the acute care guide that I created was kind of like a supplement, where it originally started where I was just pulling papers of like, okay, well, here's a research article on vent management, or like a kind of a review paper on vent management. I want you to kind of focus on this and really get to learn about vents. Right. Or like for my friend who really wanted, my coworker who was really having trouble with sensory, like here's a research article on sensory behaviors of children with autism, and here are like effective techniques to kind of help reduce it. And I would just tell my students, like, okay, well, the goal for this week is to be on like bedside swallows. Here's a paper on the 3-ounce water swallow by Deborah Suter. Go ahead and read this. And that way you're kind of understanding like the information behind it. So when they're applying it, they're suddenly then getting this extra contextual information. So it's not like I'm just saying so. They have that background information, because I want my students to implement evidence-based practice, right? I don't want them going to their next level and then suddenly whoever's like, well, why did you do it that way? And I'm like, I don't know. That's just the way the person before me did it. Because I think that is a very bad thing for our field. I think it needs to be, you need to understand why you're doing the behavior you're doing. And so like by pulling, that's a lot of what the acute care guide is it's kind of like pointing to different parts of the research in the field that says like, hey, this is why we do this. This is what it tells us. This is what researchers found. This is who it works for. This is who it doesn't work for, stuff like that. So that my students just don't just walk away and they're like, oh, hey, like, I don't know. I give them 3 ounces of water, and if they don't cough, like we're moving on, because that's sometimes what they just expect or they understand.
Yeah. Well, no, and I was in the acute care when I first started the rural hospital too, and it became a little bit more suburban as we went along, because the population exploded in the building, and like in this community changed, and so our demographic in the hospital changed. But yeah, I think that's a really great point, because I can remember when I was doing my clinicals in skilled nursing, and I still will say I was very fortunate in both my pediatric and my adult settings for off campus, because I had such strong mentors, and they were not afraid to kind of push me off the deep end, but in like the best way possible. Because it was more like without a full-on syllabus, but it was like, here's the expectation for this week. I'm going to give you this challenging patient to kind of run with, but you've seen me, and like kind of don't be afraid, because I want you to take the reins, but I'm going to be here with you. I'll be right behind you. So you get this trach patient who, is going to be trached probably for eternity, and don't be afraid, because the skilled nursing, they didn't have a respiratory therapist who came.
Yeah.
So like, I need you to do XYZ. You need to learn this, because if you're ever in a pinch, I need you to understand what the parts of the trach are. Be afraid when they cough. They're going to cough when you place a speaking valve. They're going to cough when you take it off. Don't jump. Don't freak out, because if you freak out, they're freaking out too.
Yeah.
So like things like that I think a lot of people leave out, and sort of make the student, at least in my experience, make the student feel even worse. I mean,
Mm-hmm.
grad school is like hellish in and of itself.
Mm-hmm.
It's just so dang hard. Like the coursework is hard. I was a returning adult student, so I had a teenager and a preteen and a military
Mm-hmm.
spouse. And so I had enough stress without having to do all this other stuff, without having clear expectations of a student. So I think that's really good because, again, it impacts not only the student's clinical practice, but then it's something they can take with them.
Mm-hmm. Exactly. And that's what I wanted is I kind of, in the PhD world and the research world, you really talk about like the family tree of researchers, right? Like you have this prolific researcher and he trained these people and these trained these people. I was like, well, I'm creating like my clinical family tree. And like, I want my students to be great. I know that they're going to be phenomenal clinicians, and I want them to have, because I remember my CF and it was terrifying. And one of the things is the Lydia Perkins, the SLP who trained me, she had a binder full of just research articles. And she's like, this is why Evans blue dye testing is not as like effective as we want. This is why palpation of the swallow, like through just touch, doesn't really give us the information we want. It's a good tool. You can use it, but you need to understand its limitations. And her giving that to me, I was like, this is my grail. This is what I wanted to just have and be like, okay, like this is what I need to know as a medical SLP to build my skill set. And the thing is like, I'm 4 years into this and now I have like this document that just has a life of its own and it keeps growing. But it doesn't have to start like that. It just started with like a literal 1-page syllabus. And then like the students would ask me, okay, well, great. Like, do you have any more resources on that? I'm like, oh yeah, like here's this. Let's Google it. Let's see what the resources are. And then I was just starting to like create like just a folder on my desktop. And then I was like, well, I can't just give them all these articles. Let me start like shortening it up into like little blurbs about each article and kind of pointing back to where they can pull it themselves. And then it just kind of grew a life of its own over the years with feedback from the students of like, hey, look, like I really didn't understand this concept, how do I like, is there any way that we can create like a cheat sheet or something that helps me integrate this information a little bit better or understand this information better? And it just kept going. And so, like I said, 185 pages is insane. Like I'm not advocating that you like tonight go and start on this document, but I think regardless of the placement that you were in, it just think back about like when you were a student or even when you were a CF, like what information did you, because we all had, I'm assuming that we all had that like imposter syndrome. And we were like, oh my gosh, I don't know what I'm doing. I'm missing so much information. Like I thought I knew what this was. Help. And like just start creating like those resources as a gift for yourself when you were a CF. Like what would you have loved to see? Asking your students like, hey, where are you really struggling in this placement? Where are you lacking confidence and what skill? How can I support you or how can I give you resources for that? And whatever that looks like, I think your students would be really excited to have a clinician that's pouring into them, and helping them grow. And sometimes, when you're burnout with your work and your job and the job just isn't jobbing and giving the satisfaction, sometimes you can kind of turn that lens a little bit and pour into the student. And that can give you some of that like helpful, happy feelings. And so I kind of found that was my way of giving back. And like, when COVID got too much, I was like, okay, I can just focus on this to build in too.
Yeah, that's a great point. And I, as an adjunct too, last semester was really tough. I had a really interesting group of students last semester. They were just, I don't even know the word, but it was sort of like I had this waffle back and forth of like these overachiever. I mean, every SLP is overachiever, but the overachiever to the point of like one person had like 103% in my class. and I took a half a point off a paper, and she like sent me this email this long about
Oh gosh.
why I shouldn't have taken this half a point, which dropped her to a 102.8. So I had that student, and then I had a student who never came to class or came periodically, just didn't turn in assignments and was graduating, and then wondered why at the end of the semester she had a D. And so it was really
Mhm.
interesting semester, because even though this was the seventh semester I had taught this class, I felt like, okay, like, I mean, it's grammar and writing. I think I've got
Mhm.
that. I think I've got that part.
Yeah.
Interesting, because I did have to sort of restructure some. We actually started last week, so today was the holiday, and we didn't have class today, but we had 2 classes last week, and I thought, I think I'm gonna have to do, like you mentioned, just, like, restructure some things that I'm
Mhm.
doing to kind of feel them out to see what their needs, because the undergraduates of today are markedly different than the undergraduates of my time, and even the students that I've had 4 years ago or pre-pandemic. Their learning styles have changed. The pandemic, learning virtually, now they're back in the classroom, and it's interesting. It's just very,
Mhm.
very different, and I think we're seeing that too in the newly graduated, CFs and the,
Mhm.
senior clinicians in the graduate programs. But even like moving into sort of like from that and translating that into like patient education, I've always been a huge proponent of patient education. And I think it's just incredibly underrated and often underutilized. At least
Mhm.
that's what I've seen. Um, and many people know, if they've listened to any of my webinars or even the podcast, they know that I was a partial caregiver for my dad long before I became an SLP. I was 25 when my dad had a stroke, and my dad had aphasia. So um, I never felt like we got the education as a family that we needed. I didn't really understand what any of the things physically, occupational
Mhm.
therapy wise, speech wise, I didn't understand 99% of what any of that looked like until I went to graduate school.
Mhm.
Um, so I know you're doing some research on patient education
Mhm.
practices. So, like, I know for me what my motivation is when it comes to patient education. So, can you kind of speak to what motivated you to take on that type of research? And then also, well, we'll get to the second question. We'll talk
Yeah.
about that.
Well, so I really had my first aha moment. So I kind of have a unique job in that, like, I started my CF actually in like a school setting. Um, Made it 3 months. I knew I wanted to go to medical, couldn't find a medical position. Was coming off of maternity leave because I had my son 10 days after I graduated with a master's. So it was like a bing, bang, boom. Yeah, it was rough. Started in the schools, like in the postpartum era, and then was like, I absolutely hate this. I have to get out. The school was lovely. The teacher, like everything was lovely. It just, I'm not a peds clinician. So I ended up getting into the school system or the hospital in January of 2020 as a CF. March 2020, COVID hits. And then we lost the other 2 SLPs in our facility because one moved and one had a baby. So I was as like a 6-month in CF, the only SLP at this hospital. My CF mentor, Lydia, is at the big hospital. So I still have access to her, but like I was like having to do things on my own, and like really got the opportunity to kind of like revamp some of the things that we do because I was the only one doing it. But I remember like we didn't have any education when it came to like swallow exercises or anything like that. Like we were just telling people to do things and just like walking out of the room and be like, okay, keep doing those. See ya. Um, and so like obviously very effective.
Fair. Yeah.
And then I remember my first aha moment about patient education was when I was seeing a patient in the ICU. He'd just been extubated, and I like read through the patient's chart and saw that the patient had actually just been admitted to our academic institution like 2 weeks before. He had dysphagia and was discharged on thickened liquids. And then he shows up at our hospital, respiratory distress, reintubated. And so he was extubated. I'm seeing it. And I'm like, oh, hey, like I saw that you were on thickened liquids. Have you been drinking those like while you were out of the hospital? And he goes, oh, no, I haven't. And I was like, oh, why not? And he goes, well, I didn't know where to find them. Right. So there was like no education and through probably like likely no fault of anyone, it just wasn't really thought about. Right. And like SLPs, like we're not really like made aware that a patient is discharging. Sometimes it happens before you can do anything. Right. So, but this patient very clearly had that lack of education about like, oh, hey, you need to get thickener now. This is where you need to get it. So like, I was like, this will never happen again. I'm gonna start doing all the things. I'm gonna educate my patients out the wazoo. They're gonna be the most educated on their like dysphagia, their swallow function, whatever. And as I'm like typing up, like that Jim Carrey meme where he's just typing on the computer, I'm just like going in, typing up all the things, and then I have a moment of like, well, do I even know that this is going to be effective? And I was like, I actually don't know how to provide patient education. And I kind of took a step back and I was like, I was never taught explicitly like what patient education is, how to educate a patient, how to ensure that they understand, how to ensure mastery, prolong, like all the things that we look for in research, right? That it was effective, that it generalized, it had continuity of benefit. I was like, I don't know how to do any of this. And then I start looking around and there's nothing. Like there's no like, and a lot of times we're just like wanting to throw a sheet of paper at it and be like, oh, I educated them all the way. And then the patient, there's the patient doesn't understand the material because either the font is not in a good size. There's too much wording. There's not enough wording, too many images, not enough, right? Like their healthcare literacy is not there. Their actual literacy is not there. And so I was just like, oh my gosh, like this is not a simple fix. This is something that like I actually need to really take a deep dive into and figure out for myself what we're doing here. Because I don't know what to do. And I feel like, we argue that like, oh, it's just teach back. Like you teach them and then they teach you back. And like, we're also dealing with patients who have cognitive deficits.
Yes.
Who literally like don't have the short-term memory or like their executive functions are poor. Like it's just not there. And so I started a systematic review. We have the University of Tennessee Health Sciences Center and they have librarians there. And one of my friends is actually like works there and got her master's through there. And I was like, hey, do y'all happen to like do systematic reviews or like help people out? She's like, we do them all the time. What's your topic? And so they were able to like do a lot of like the research, like pull a lot of the articles. And I'm working with the team of SLPs in the community to look at this topic of like, what are patient education practices within the acute care setting, right? Because now we've got this issue of like, I'm only with you for 2 or 3 visits, if that. Like nowadays, a lot of these patients are going home because like our hospitals is pushing this home first initiative because SNFs and LTACs and all that insurance just isn't paying. So patients are having to go home before they can go anywhere else. Well, that means that they're likely not getting a SLP caregiver or anyone interacting with them for a minute, because in Memphis, at least, like our SLP home health has been really short staffed. So there is no one to follow up with them. So like it used to be that like acute care OL, just like they'll learn about in the next setting. Well, now like in the current 2024 healthcare landscape, that's not a thing anymore. Like we're a one-stop shop. We have to set you up for long-term success by the time you leave acute care, which is wild in and of itself. But like now you're putting professionals who like have no actual training in patient education. So we're working on a systematic review to figure out like what our practice is. And we're having to look outside of like speech. So we're looking at like heart failure, diabetes, like COPD, like a lot of the big things that they're trying to educate and reduce your 30-day readmission rates. They've got some really good like studies on education practices in the hospital. But then I was also like, well, what are other SLPs doing? Like, surely I'm not the only one who's like acknowledged that suddenly like, oh, I actually don't think I know how to do this. So I did a survey study. So you guys might have seen me bombarding, I think like SIG13 and a couple of Facebook groups, like trying to get some answers on like clinical practice patterns. Like what are SLPs doing to get experience and understanding of what patient education is, how to ensure that you're actually educating the patient, which is your goal, how to ensure all these other things. Are there classes you're taking? Did you learn about it in school? Just to kind of get a sense of like where we are in the field. And so I'm in the process of analyzing that data. So I'm a visiting assistant professor through Memphis. And so like using their IRB, but then also like, Methodist connects with, I think we connect with UTHSC. So I'm like kind of just doing this as a clinician because I was like, well, these are a little bit easier studies as a clinician to conduct. And I have the experience with my PhD. So like, let's figure it out and see what's happening. So I hope to have the results of those studies here within like the next 6 months or something. But
now, are you guys affiliated or like a stroke magnet hospital at all?
We're with DNV, so we
Okay.
are a primary strokes. I should know this because we do that stroke education. I think we're primary stroke center.
Total reason was same with the hospital that I was at previously, and so we had this stroke educator who's typically in the nursing side of things, and so I've seen the gamut run of a nurse educator who would physically like schedule time with the patient when I was in IPR or in acute care. We had one stroke coordinator who would schedule time and treat it like an appointment, treat it like part of the therapeutic process. And then I've seen other people who are like, oh, they're at their MRI. Great. I'm going to go drop this booklet off that's created by the hospital. And again, like you mentioned, and this is another like big proponent of mine is color pictures, font size. We've got hearing impaired patients. We've got cognitively impaired patients. We've got visually impaired patients. Are you giving them access to what they need? You've got people with low health literacy or limited health literacy, and not any fault of their own, but we're not accessing those patients if we're not asking the right questions. And I think that's a great point that you make, because this was more like an on-the-job training thing for me based on where I worked and even where I grew up. Because where I grew up was a more suburban, the big industry was the shipyard. So like that's where my dad worked. So all my friends, for the most part, their parents were shipyard workers in some way, shape, or another. There's a lot. I'm on the East Coast of Virginia, so we have a lot of ports here. We have a lot of shipyards here. We have big, small ones. We have military ones. We got the largest naval base in the world. So I say all that to say we have such a wide variety of folks and need. And so I think one of the things I did early on was I took a counseling for SLPs course. And I think I thought of it as counseling. It's almost like, I don't know, I'm thinking like marriage counseling, like what is this? But that is exactly what it was about, was using counseling techniques like active listening, supportive listening, feedback to the patient, not just having them do a teach back, but making sure that, okay, maybe we need this in Braille. Maybe we need to get an interpreter for ASL for their ASL dialect. Because I think, a lot of times we hear we have to use the hospital-based interpreter, or we're required because of the stroke magnet program to use the hospital-based educational information that's been formatted ninth grade education. And that's not always effective for the patient, and it's not effective, and it doesn't work. It's not a one size fits all.
And it can be incredibly frustrating. And we were talking about this earlier of like, even as a PhD, but even as a clinician, when you consider that, in both of my careers, they are largely educational. And at no point have I taken an education course to understand, didactic education, or how to ensure understanding, or the difference between like knowledge and performance and mastery and all of that. Like, I have a master's in psychology. So I actually took those courses, and through their graduate programs, they require you to take these teaching courses. They require you to teach before you graduate with your PhD, so that you have that experience and understand how to craft a course so that it meets the needs of the student and accurately or adequately assesses the content. But I felt like, I think it's I don't want to, for this to be viewed as a bash against the University of Memphis, because I love that program. I'm teaching in that program. I think it's more of like, I don't know if it's an ASHA thing or just the state of higher education, where we're like, as PhDs, we're pushing the research, but we're not pushing like this large area where like we are teaching future clinicians. And like, are we wasting our time standing up there just like talking at people when we could actually be like working on creating these really good courses that fully like connect with the student? And I think that that's what we're starting to see, especially as like more Gen Zers get into the classroom setting, and these COVID these post-COVID students, and as our patients get older, and they tend to be more like Gen Xers, millennials, and stuff like that. Like, the way that we connect with them it has to be different than the way that we connect with boomers or the silent generation.
Yeah.
They're just expecting different things. And I think whether through like a course on patient education, or adding that into counseling, or through an actual education course within the PhD program, for our field to be so education based, it is a large glaring component that is missed, because we are educating everyone we come in contact with, no matter what we're doing, right? So like, as a SLP, I'm educating the patient on their diagnoses. Like, I'm pathologizing and telling them what they're doing. I'm educating family. I'm educating the nurses and the physicians about like, hey, look, this is why we don't thicken liquids at bedside. This is why we, in an acute care setting, this is why we need to do a modified first. This is what I think is happening. But if we're not able to effectively communicate and educate that to people, like, what are we doing? We're kind of like selling ourselves short. We're not actively helping patients, and we're not allowing for informed consent, because a patient cannot consent to something they don't understand. And I think that is a huge component that we are missing, is that we can like really quickly be like, oh yeah, we're going to do a modified this. But unless we ensure that they actually understand what that procedure is, that's not really informed consent. That's just, oh, okay, like they said I needed this, so I don't know what it is.
And that's a great point, because that's the old model of, even like with my in-laws, it would drive me nuts, because they go to the doctor, and the doctor would change their PCP, would change their meds, and they went to the cardiologist, and the cardiologist changed their meds, and now they're not PCP's doing this, and the cardiologist doing this, and no one's on the same page. And it's like, stop doing it just because they said to do it. Like, ask the questions. But that is, like you said, fundamentally and generationally not who they are. And it informed consent is huge, and a lot of people are talking about it. I feel like for me, I don't know that I guess I did know, because I started doing fees as a brand new. I was a CF when I went to school for fees, and when I started passing the scope and like getting all my things, my checklist done. And informed consent was something that we had to do, because that was not something that was covered by the consent to be admitted. We had to go through and explain the procedure. And if it was a patient with a cognitive impairment, we had to make sure that we had either the next of kin or whoever, the POA, power of attorney, if they had one, we had to have all those things all the way together. And if you called them on the phone, say they were a child out of state, or the spouse was not able to come in that day, or whatever, you had to have a witness on the phone. And so I learned that in a sort of a different way. But again, I think when you learn it early on, it does change how you practice, or hopefully it sticks and changes how you practice, because you have to become more aware and more mindful that the patient's Bill of Rights that hangs on the wall in our hospital says they have the right to say no. They have the right to refuse. They have the right to not undergo further testing if that's the way that they want to go. And I've seen so many times that a lot of clinicians still try that coercion technique of, but you need honey thick liquids, but you need this, but you need that. Well, who's that benefiting in the end? And so I think that was a really good point of looking at what your research is looking at, and sort of trying to figure out what motivated you to do that, and then kind of what you aim to answer through the study? And is it kind of gearing towards education and informed consent, or a little bit more than that? Does that make sense?
Right now it's just geared towards patient education. But I think like as I'm getting into this a little bit more, like I really find like the whole like healthcare literacy component fascinating. I jokingly tell my graduate students, I was like, well, if I had my own program, like we would all like have SLPDs. Like I think I will argue that I believe that our program, especially if you're going to specialize like in an area, like I think an SLPD, we need more time. We need more classes. We need more education. And I think like a healthcare literacy class or like a public policy or public health class is really necessary to kind of focus on that. The informed consent is something that I've just been gradually like kind of, listening to people, and especially like, listening to like, everybody got on TikTok during the pandemic, but like listening to people who have like had their trust violated by healthcare professionals because, they either didn't give informed consent or, or a lot of the things is too, like as professionals, we have to be aware that informed consent is continuous throughout the whole process, right?
Yep.
Like, so for example, like during my modifieds, I'm talking to my patient and say, okay, this is thin barium. It's going to taste a little chalky. I like literally have the same spiel every time. It's going to taste a little chalky, kind of like Pepto-Bismol or Mylanta. I need you to take a teaspoon. And then I go to, we walk through that and it's like, okay, this is mildly thick. This is going to be about the consistency of a smoothie. I need you to do this. And then going in, and then I even give a barium tablet. This is a tablet. There's no medication in it. It's just a pill version of what you've already been given. And some of my patients say, I don't want to take the tablet. And I say, okay, well, so this tablet will allow us to see that when you take your medication, and sometimes you complain that pill gets stuck in your throat. This will allow us to see like what's happening. Is that pill getting stuck, or where along the process is it getting stuck? And they say, you know what? I really don't want to. I know it's going to get stuck. It makes me uncomfortable. I say, okay, you know what? Not a problem. Moving on. They have given me consent at every step of the way. And at the point that they are no longer consenting, moving on. You're like, I have enough information. We can kind of make some guesses about what's going on with that tablet based on the physiology from the other trials. But like at the end of the day, like their autonomy is important. And I can't push through that. I even do it with like, walking through my clinical swallow evals, and like, patients are like, why, like when I'll do a cranial nerve and I'll have them like doing on their faces, I always say before, okay, I'm going to ask you to do what may seem like some silly things with your face. What I want to do is I want to see if the structures responsible for speaking and swallowing are moving the way that we expect them to. And then every time the patient's like, oh, okay, perfect. Like, sure, you asked me to do weird things, but now suddenly it makes sense. And I don't feel like you're doing things to me. I feel like I'm doing things with you. And if they say no, then I usually just say like, patient declined to participate, no overt asymmetry, right? Like I can still get information without like violating their autonomy or their trust. Because the fact of the matter is like a lot of these people have had negative experiences. And I don't want to add to those negative experiences.
Yeah. And I think especially when you've worked in a more rural setting, we see that because, a lot of the patients that I work with early on, because when I first came to the health system I was working at, I was working in the big trauma, the level 1 and the level 2 trauma, two hospitals, and then I started covering this other more rural, and that's where I sort of landed because it was closer to home and it was whatever. And quite frankly, at the point where I was trying to cover a 6-building campus by myself and running all over the place like a nut job and couldn't get anything done. Yeah, I'm going to go to a rural place where I feel like I can do something to affect some change. So I say all that to say that I had such an interesting caseload mix, particularly early on, because I saw things that weren't really typical in the general population. But then also I had some patients who were mistrustful of me because of me being a white female. And I had to take myself out of that equation. And a lot of times I don't think people who haven't had that experience or worked in a more rural setting with a lot of people whose backgrounds are markedly different And I think you can get that at a bigger hospital, but I don't know
Yeah.
that you're so much more, you have so much less time. And like when I was there and I had 9 patients versus 25 by myself,
Mhm.
I could spend more time with a 9-patient caseload
Mhm.
in acute care because,
Yeah.
that's not really typical, but
Mhm.
I got more perspective out of
Mhm.
that. And
Yeah.
so, when you're thinking about kind of the outcomes of the research projects and just how that impacts the field overall, I think we can kind of tie those two things into the education practices for both patients and graduate students and kind of seeing how those really intertwine.
Yeah. So I think the biggest piece I feel like is sometimes I don't know if it's our field, I don't know if it's academia, I don't know what it is. But I think sometimes the assumption is, oh, well, to educate someone, I just need to say it to them. I just need to say it out loud. They soak it in, and then we move on. I've educated them. And I feel like that's not a given. And especially as we're working with different generations of people from different cultural backgrounds, people with different levels of education. It's like, for example, like my hospital, like primarily, like my patients are 60 plus and they're primarily, Black. So like different expectations, different life experiences. Like it's really presumptuous of me to walk in there and be like, oh yeah, I educated them. Like I told them and they're good. They're moving on. When that's, there's so many layers to be considered that I'm just like glossing over and just assuming that, handing them a sheet of paper is going to be enough. Same with students. We are getting students at Memphis. We're getting students from all over the country. We're getting second degree or second career. We're getting fresh out of undergrad. We're getting international students, different life experiences, perspectives, whatnot. And to just like carte blanche, like throw education out there and say, okay, here you go. Here's your education that you paid for. Like go do things with it. Like it's really presumptuous. And I think that there needs to be a really conscious effort on the part of the professor, on the part of the clinical supervisor, on the part of the clinician to invest in themselves and their patients and their community to find ways to connect with others. Because that's what education is, right? Like it's the transfer of knowledge from me to you so that we can connect, and we're giving you power for yourself, power for the clinician and the student, or like the graduate clinician, the student, to learn and master a topic, power for the patient and the family to understand what is happening to them, and grow and treat it to the best of their ability. And I don't think that can be done just by like throwing things at people. I think we need to really have a systematic, conscious movement where we learn how to educate. We learn how to connect in a meaningful, powerful way. We're not there yet. Like, sure, like my little study, these are just random studies, but I hope, and that's in part why when you reached out to me about like doing a podcast, I was like, this is kind of like not the soapbox I saw myself on. At the end of the day, I feel like I connect with people better. And I feel like I build rapport better because it allows me to see the patient, to understand who they are, where they are, see the student, understand where they are, and adjust like what I have for them, which values them and raises and puts them at the forefront. And I think that sometimes even with speech language pathologists, I think sometimes, we get accused of being ableist or, trying to like push people into categories. And I think it's largely because like we make these assumptions and we just tell them to do things. And, our education isn't being crafted, and sometimes our treatments aren't even taking into account who the person in front of us is. So like that's just one of those big things where I just want to shout it, be like, hey, like we need to do more to be the helpers that we all wanted to be. Otherwise we wouldn't have gotten into this field.
Right. Well, even if you back up, in talking about your psychology background, but even like basics, Psych 101, Maslow's hierarchy of needs,
Yeah.
Safety, shelter, food, right? So if you're taking someone out of their environment, you've moved them into, maybe they have shelter, but it's not their shelter.
Yeah.
Now you're altering their food. Depending on what their background is and where they came from, they may not feel safe. So you've already fundamentally set them up for not feeling whatever it is you're about to throw down anyway, because their basic 3 needs are, for safety, shelter, and food are not being met at the most basic level. And then we come in and especially with the food, how many times have you gone in and done them, and I think, again, when you've done instrumental exams, your perspective changes from day 0 to by the time you've done 500-600 modifieds or 600 fees or combination of both, your perspective is, at least mine, is so markedly different than it was when I just had the fundamental brain knowledge of the anatomy and physiology and how that's supposed to translate versus looking at the patient holistically and seeing what their need was, their goal was, their family, their caregivers' goals. And shared decision, social determinants of health, all of those things to our practice. And again, as many times as I've talked about both of those things, whether it was on the podcast, whether it was a webinar, whether it was at a conference, whether it was to my colleagues, it still is not widely being practiced. So I think that is kind of the thing that leads me to just future approaches to education within the field, and then looking at, your research and what implications that should hopefully trickle down, not only to the clinicians, but to patients and their families.
Well, I think too, like, understanding education is inherently patient-centered care, but it's also evidence-based practice, right? Like, how can we say that we're using evidence-based practice if there's no evidence on how to do patient education? And especially, like, we're missing the whole component of, like, I just started this working with, like, people who have swallowing disorders, who have functioning, for the most part, functioning cognitive and language abilities. Like, that even doesn't even get into, like, how can individuals with language disorders or cognitive disorders have informed consent? How do we ensure effective education? And, like, there are times where, like, I have to, like, part of our documentation, it talks about, like, education, who did you educate? Like, what was the response? And a lot of times, like, for example, with my dementia patients, I just have to be like, clinician informed, unable to determine level of understanding based on current mental status, right? But, like, sometimes, like, with language disorders, how do we, and someone's got, like, a receptive language disability, cognitively they're good, but, like, how do we're working with these patients, and sometimes their caregivers aren't in the room or their loved ones aren't there. So, like, it's just this big area where I think it's just we haven't gotten there yet. I have faith, and I really am like hopeful that we will get there, and that it will be important and we'll push through. But we're just unfortunately not there yet.
Yeah, no, I agree, and it's just a lot of room for growth. And I think, again, like you said, a lot of room for researchers to have that more implementation science, right? So that research that is able to be implemented by the clinicians, because again, that's been a gap for a number of years. Was that even when we were in school and looking at some of the research that came out, and it was like, oh, that's a cool technique, but I have no idea what the heck and how the heck, who the heck, and
how am I going to get this $20,000 piece of equipment that you have to use it on Monday when I go back to work?
Yeah, exactly. And even like with our fees, again, when I first started, I was in inpatient rehab and covering LTAC. So we had fees. We had two fees. It was almost 15 years ago. Well, 14 years ago. So then I went to acute care and we had 0. And it was like, what? But it took like 5 years of that being in the capital budget and, like, having a boss who was supportive and fought for it. And then when I went to outpatient, having 0 support and not to get any of that in the capital budget or even fought for as a viable piece of equipment. And when you're dealing with your head and neck cancer patients and you're not having immediate access to instrumentals, that's another one for, like,
Well, and
implementation
like,
research
that's what
side.
exactly, like biofeedback is a powerful form of education. Like I use modifieds, like we do outpatient modifieds. I
Mhm.
see people come in and they are like complaining about globus sensation, and almost immediately I'm thinking, okay, it might be esophageal.
Close.
Like we need to look down there. And then when it is esophageal, I spin that screen around and I show them that their throat is empty, and then I walk them through the sensation of the esophagus and why they're feeling that referent sensation. Just that extra step of education using the biofeedback from the instrumental helps them, and they're like, oh my gosh, I have been, it just feels like it's in my throat, but now that I know it's in my esophagus, I'll drink a little bit, I need to go to the GI, right? Like they can connect and they can understand their body on a whole different level than me just like being kind of casual, like, oh yeah, there's nothing there, you're fine, like your swallow's good, go. Right? Like that's dismissive. Whereas when you
Mhm.
take the second and you step back and you say, okay, I really understand your concern, and I want to tell you that your swallow looks great. Like your oropharyngeal swallow looks phenomenal. However, I do understand that you have this globus sensation. I'm not seeing anything here. However, that doesn't mean that it's not further down. Let me tell you about what the esophagus does. That's
Mhm.
what, 3 minutes of your day, but
Yeah.
now your patient goes from, well, I just wasted my time getting this study and was kicked out of the room and made to feel like an idiot, versus like, oh my gosh, like, now I understand and I feel like somebody finally believes like that I'm going through something. And
Mhm.
like that is such a powerful shift, and just using your tools to educate someone about like a function of their own body.
Yeah, especially when it comes to swallowing or even like with voice, and I'm not a voice specialist by any
Mm-hmm.
stretch. I'm more of a voice referral, but like I'll refer you because
Yeah, exactly. Same.
I can do some education and stuff. But if
Yeah.
you haven't been to the ENT, I'm not touching you with a 10-foot
Mm-hmm.
pole. Especially like otolaryngologist, that's who you
Mm-hmm.
need. You need to go there first. Same with swallowing in the
Mm-hmm.
outpatient setting. I need you to get
Mm-hmm.
an instrumental first.
Mm-hmm.
Even if it's been 6 months since your last one, you need a new one because we
Yeah.
don't know what's happened in those 6 months, and you
Mm-hmm.
could have had something change. Um, and again, educating as to why, and not just saying, I need you to do this and you will
Mm-hmm.
do it or XYZ.
Exactly. Exactly.
Yeah.
Mm-hmm.
So, it's we've gone over our hour, which is
Oh,
great, but
okay.
I don't see
Sorry.
I don't see no, 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 that's great. I don't see any questions in the chat box right now. So if you all
Mm-hmm.
have any questions, please put them in the Q&A or the chat box. But in the meantime, Megan, I think you and I both knew kind of we've talked before, and so I think we
Yeah.
both that these topics were priority for both of us, and I
Mm-hmm.
think it's great because generationally, as we move forward, like you said, with some of our patients and in these different categories, these we're used beginning my career, I was getting the boomers and the silent
Mm-hmm.
generation, and now the youngest patient on my caseload a month ago was 29, TBI
Mm-hmm.
patient. The oldest was 91.
Mm-hmm.
I was seeing everything across the gamut, and so you have to adjust um, that mindset and making sure
Mm-hmm.
you're looking at those generations and what their expectations are for things like informed consent
Mm-hmm.
and decision making. So thank you for bringing that up.
I think too, and especially like what you were saying with the counseling, like those classes are important because we want to make sure that when we're educating, like our message is actually getting across the way we intended, and we're not just like being really like, sometimes the tone alone can be enough to derail the education. So like there are just layers that like we really have to take a step back and like figure out what is how are we being successful, when are we being successful, and what could make us more successful.
Yeah.
So I always like to our my outpatient clinic that I'm about like 10-15% of the week, and they really push like we should always ask our patients at the end of the session, did I address all of your concerns? Was there anything that you wanted to talk about that we didn't talk about? And those are really great moments for me to realize like maybe where I missed the ball on education, or maybe where we needed to connect with the patients a little bit more. So maybe even simple strategies like that of just asking your patient like, hey,
Mhm.
what do you want? What do you want to know about? Like, where are you confused? And sometimes, if they've had those negative healthcare experiences, they just may be interested for the situation to end and don't want to keep going. And that's fine, right? You're not going to cure healthcare in the system overnight, but like giving them the opportunity. And as you continue to give more and more, as everyone continues to give the patients more and more opportunities to voice their concern and to speak to us, and ask questions, I think that's going to be what really helps us.
Yeah, no, I think that's perfect. Thank you so much, Megan,
Yeah.
for being here tonight. I really appreciate you coming on, and certainly you're welcome back anytime. Thank you again for being here, and we look forward to seeing you again.
If you have indicated that you are part of the ASHA registry and entered both your ASHA number and a complete address in your account profile prior to the course completion, we will submit earned CEUs to ASHA. Please allow 1 to 2 months from the completion date for your CEUs to be reflected on your ASHA transcript. Thank you for joining us at today's podcast. Remember to go to speechtherapypd.com to learn more about earning ASHA CEUs. We appreciate your positive reviews and support and would love for you to write a quick review and subscribe.